Hello, hi, this is Dr. Michael Watson from Arizona Jaw Surgery. I'm here to talk to you briefly about TMJ arthroscopy. Again, brief synopsis here that hopefully will help give some information about TMJ arthroscopy. For more information, go to our website, azjawsurgery.com. If you feel like this is something you want to discuss with us further, again, always reach out to us. We're happy to meet with you virtually or in person to discuss your TMJ condition and whether or not this or other procedures may be applicable to you. So briefly, what is TMJ arthroscopy? Arthroscopy essentially means examining a joint through a small camera. It's a minimally invasive procedure that allows both diagnosis and treatment of most intra-articular TMJ conditions, not all. Sometimes that's depending on the level of severity and the specific of the condition, but a lot of things can be treated with this minimally invasive approach, which we try to utilize as much as possible because it is minimally invasive, which means that the morbidity and the risk are much lower than the open TMJ procedures, meaning an incision is made to actually go into the joint. So the benefits of this to the patient is that the recovery is far less because of the minimal nature. The scarring is so much less and pretty much just non-visible, which we'll show you. And then it's also a very good diagnostic tool. We have CT scans, we have MRIs. These have important roles in diagnosing TMJ conditions. But there's not much better way to look into a joint than actually to be in there and looking around, because there's limitations to TMJ CTs and TMJ MRIs in what they can show you, because they're still images, or sometimes you can have them with motion, but they're not showing live tissue in real time. And that's one of the benefits of arthroscopy. So how do we do it? Again, a few ports are put in, usually 1 to 3. You can put more in, you can put less in. You have to have at least 1 to put the camera in and actually look around, and then at least 2 to actively treat the condition surgically with other instrumentation. So the first port, camera, that's what allows you to look around, see, diagnose, visualize the joint. Any other port you put in after that usually is for an instrument of some kind, and this can be lasers, it can be forceps to help you biopsy tissue, shavers, ablators, other things that allow actual treatment of what you find when you're in there. And the combination of these two things can allow a number of procedures to be performed. If you have scarring or adhesions from chronic inflammation in there, we can break those up to make the joint expand, make it more mobile and functional. We can debride the disc itself. So if your disc has perforations or tears on it, that's usually kind of something that lowers the long-term prognosis of your condition, but we can debride it and clean it up to help it last as long as possible. And then if your disc is stuck or it's malpositioned, we can do procedures to help mobilize it, to help free it up, to get it to be more functional so that your function and mouth opening, chewing ability increases, your pain level hopefully goes down as well. Now, just because we can do things doesn't always mean that we should. So you could have a displaced disc, you could have conditions, and you might say, well, why don't we treat it this way? And some things we just know the prognosis isn't as good with certain things, but these options are all on the table. What does it look like within there? So there's different ways we can look at it. Here's a couple of still images. This is the posterior aspect of the disc and the tissue that attaches it, or the retrodiscal tissue. From an arthroscopic anatomy, we kind of often call this an oblique protuberance. Here's the medial wall. So this is kind of going internally towards your musculature in there. Here's a very inflamed joint. You can see how red and angry this appears. Look how much vasculature there is. This is an inflamed joint that needs to be addressed, because this patient, you can just look at this and say, oh, that patient's in substantial pain. Video, we can take video recordings of things like this, and here's showing a very significantly diseased joint with a lot of cartilage breakdown. You can see there's cartilage literally hanging from the walls of this joint. This is the joint moving, so I'm moving the mandible while I'm recording this. Hard to even see much because this joint is so destroyed. It's just got bands of loose cartilage everywhere, which could mean that there's actual pathology. We could take little bites of tissue of this and send them to say, hey, is this a benign tumor? Is this just cartilage breakdown? Is this potentially a systemic arthritic condition with this level of breakdown? A number of things to kind of look at in there. Recovery-wise, always an important question. Pretty easy. I don't want to, I always hesitate to say that, but that's a comparative kind of terminology. Compared to opening joints or other bigger procedures, this isn't so bad. Now, it's not all sunshine and rainbows, of course. There's some pain, there's some discomfort, there's some swelling. As you see here, there's some bruising. And I show this picture all the time when I discuss arthroscopy, because this is a mid-50s female when I practiced in Seattle, pale, thin skin, old enough to where you're not a teenager and healing overnight, but not so old that you know that the incisions are hidden by wrinkles substantially or other things like that. And she's just a tiny person. She's maybe 5 feet tall, 95 pounds. So this is kind of as bad as it gets. I mean, this is the patient, if you had to paint a portrait of who would show bruising, swelling, scarring, it's this patient. And as you can see, this is 6 days after, and there's just almost imperceptible amounts of scarring, and you do see the bruising there. But again, this is about as bad as it gets. So we generally will say, hey, take a week off. This patient actually went back to work after 3 days. And that's reality for some patients. If you have kind of a light workload, you're at a desk, a phone, you work remotely, you could be back doing normal things. If we did this on a Friday, you might be back at work on Monday. It can be that. We want you to overplan and prepare, but the reality is not a lengthy recovery. We don't really want you chewing a lot the first week just to let things heal, settle, calm down. And then physical therapy afterwards is crucial. Doing this without it would be completely useless. Again, do you have to see a physical therapist? Do you have to be doing a routine or leaving work to go see them? No, but you have to be doing some of the stretches, exercises that we will be giving you, or working with the physical therapist, which, depending on your mentality and your needs and how you're responding, may be a huge benefit to you. And again, almost immediately there's improvement with this. You do trade a little bit of the pain and limited function you had as a way of having a TMJ disorder for having a procedure. So you'll have procedural pain and swelling, but this pretty quickly goes away, and then you kind of notice, wow, I'm feeling better pretty quickly. So who are candidates for this? We talked about it a little bit, but these are for patients that have intra-articular TMJ disorders, meaning the joint is within the disc itself. And this sometimes is confusing because most quote unquote TMJ disorders or TMDs are muscular in nature, meaning you have a grinding habit. You clench or grind your teeth in your sleep, or you chew gum, or for whatever reason, your muscles are just constantly tired, achy, and sore. There's no surgery for that procedure. We wouldn't even consider this as an option for those candidates unless they've exhausted all the other treatment options, and it's more of a thought process of, hey, are we missing something? We think this is all muscle. That's what things kind of indicate, but we're not responding to the non-surgical treatments. Maybe we should go in and take a look in the joints just to make sure there's not something we're missing that could be addressed and help the patient. Some examples of these would be anterior disc displacement with painful reduction. So these are patients that have a click or a pop when they open, close, or move their mouths, and it's painful. If you just have a click pop of your TMJs when you open, close, that is perfectly fine. That's considered a variant of normal. We can't really make that a lot better in a risk-reward balance. Like, why would we subject you to a procedure when you don't have pain, you're functioning fine, but you just have a click? If that click starts to become painful, it's starting to lock a little bit, it's difficult for you to make that click happen, and it's just kind of starting to affect you, then yes, then TMJ arthroscopy is a very good indicated procedure for that. If your disc is displaced and it's not reducing, so you no longer have that click or that pop and you're stuck, you can't open very wide, it's painful. Again, very good indication for TMJ arthroscopy. Synovitis or inflammation of the other synovial tissues that surround the joint, other kind of disc disorders. Again, good first-line treatment for these kind of conditions. And again, as I indicated before, if you're doing non-surgical treatment, like we think this is either a muscle disorder or you made the decision that, hey, I want to try non-surgical treatments first, but you're not improving, or you're not improving enough, or if you got a little bit better, but you're still not happy with where you are, eventually you have to kind of sit back and say, okay, well, if what we're doing is not working, we need to try something else. And TMJ arthroscopy, again, being minimally invasive, is a good option to go to kind of as a next step. In general, the other trend we're seeing within the TMJ literature, and those of us that do this, is that when you're deciding between surgical and non-surgical treatment, we're seeing substantially better outcomes with early minimally invasive treatments such as arthroscopy. So if you had one of these articular disc disorders, traditionally you would exhaust or you would try non-surgical treatment first. Still a reasonable option, and that should be patient specific. They should make that decision. But the patient should be informed that given the two options, minimally invasive surgery and non-surgical treatment, we're seeing better outcomes with early minimally invasive surgical treatment. We would never make incisions. We would never open people up early. But for the minimally invasive stuff, such as arthroscopy, where there's minimal scarring and risk, doing that as a first line treatment has been shown to be more effective in pain control, improving function, and need for treatment long term. So that's somewhat new and somewhat out there. And we as providers sometimes meet resistance to that because it goes against traditional thought, but that's the newest and best evidence that we have currently. So hopefully that was helpful. I know that's a lot to digest. Again, head over to our website. If you want more information, we're always happy to meet with you virtually in person, whatever works best for you. If we can be of any assistance, again, azjawsurgery.com. Call us, reach out to us. Hopefully that was helpful, and have a good rest of your day.